Good morning. Can you hear me?
Morning, sir.
Can you hear
Yes,
me?
sir.
That's great.
Yes, sir.
That's great. That's great. Good morning to one and all. Today, Sunday, tea breakfast session. We have two experts, Dr. Kirubanand and Dr. Pooja Natarajan. They will go take us through today's session. Feel free to ask questions at the end of the talk. Both of them are accomplished cardiac anesthesiologist with experience in echocardiography. So we look forward to the talk. Now hand over to Dr. Pooja Natarajan, please.
Hi, everyone. Hi, Kiruba. Welcome to our forum. So today, Kirubanand will be talking on chamber quantification and hemodynamic measurements in TE. Kirubanand is working as a consultant in CM. He has great interest in echocardiography. Over to you, Kiruba. You're not.
Sir, unmute your mic, sir, please.
Unmute. Kiruba, unmute. You're mute. Yeah.
Am I audible now?
Unmute your mic, sir.
Yeah. Thank you,
Yes,
Dr.
sir.
Pooja. Thank you, Dr. Muralidharan, for giving me this opportunity. So I'll straight away go to the presentation. Is my slides visible?
Yes, we can see.
Yes, yes. So for the next 30 minutes, we will be discussing, I will present about the chamber quantifications and their latest guidelines and the updates available in that. And last session will be on hemodynamic measurements and the basics of the various hemodynamic measurements I will discuss. So to begin with, American Society of Echocardiography and European Association for Cardiovascular Ultrasound came with recommendations and updates. In 2015 is the last update, which gives various normal range and various techniques and methods to measure the linear measurements and volumes of cardiac chambers. So all these normal values and methods are based on transthoracic echocardiography. So these are adapted to TEE. The same committee also recommend the normal reference values mentioned for transthoracic can be applied to TEE. But unfortunately, not all the standard views measured by transthoracic can be viewed by transesophageal echocardiography. So few modifications are available, which I will mention in the further session. So whenever we do echocardiography, the ECG monitoring is very important for timing the various cardiac events. So if the patient is in sinus rhythm, the values whichever we measure, we should be averaged over 3 heartbeats. The patient is in atrial fibrillation, the value should be averaged over 5 heartbeats. And all the measurements should be indexed to body surface area to reduce the interpersonal variability. So the ECG, few notice that there is a electrical and mechanical time delay. So the electrical activity starts early in the myocardium and the mechanical follow that. So the peak of the R wave coincides with the end diastole, while the end of the T wave coincides with the end systole. Please remember this for the further discussion. So first, for the purpose of quantifying left ventricle, it is advised to take transgastric views rather than the midesophageal views because there are lateral wall dropout are more with the midesophageal views. But this is not the problem with the transgastric views. So transgastric two-chamber view is used. Here, the internal diameter of LV is measured at just a distal to the tip of the mitral valve, and this caliper should be perpendicular to the LV long axis. So, and it should be measured from the inner edge to the inner edge. For measuring the long axis, midesophageal two-chamber view is better. So the measurement should start from the mitral annular plane, not from the tip of the mitral leaflet, and it should be measure the deepest part of the LV cavity. And foreshortening should be avoided. So it should be measured in the two-chamber view and also the four-chamber view, and the value should be average, and the average value should be used for further calculations. So for the purpose of measuring septal wall thickness, it's better to use a transgastric mid-papillary short axis view. So the measurement should be done at the end diastole. So posterior wall thickness can be measured from the epicardium to the endocardium. Similarly, septal wall also can be measured. So this is useful in case where there is a symmetric hypertrophy of left ventricle. In a situation where there is a asymmetrical hypertrophy, mediasesophageal views can be used. Mediasesophageal long axis view or mediasesophageal 5-chamber view can be used to visualize the basal hypertrophy of the septum. Also, 3D is much more accurate than the 2-chamber views. 3D views gives the entire thickness of the septum, and also we can measure the depth of septal thickness, maximum thickness from the aortic canals. So these are the normal values of LV dimension measured by linear methods. So the highest diastolic measurement internal diameter is 3 centimeter in male, and in a female it is 31 millimeter. Left ventricular end systolic diameter in male is 21 is the highest normal, and same thing in female also. So the LV dilatation can be quantified based on their diameters, mild, moderately, and severely dilated based on these values. So since that volume calculations previously they used to do based on the linear methods, which assume the LV cavity to be bullet shaped, which is not the situation in most of the cardiac patients. So these linear methods should not be used for volume calculation, and the American Society of Echocardiography recommend the disc summation method or Simpson's method by using the biplane technique. So when there are 2 or more contiguous segments of endocardial border are not visualized, better not to do the biplane disc summation method. So in that situation, we can go for either area length method. If contrast is available, it can be used to enhance the contrast between the LV cavity and the endocardium. So for the purpose of biplane disc summation technique, 4-chamber and 2-chamber should be visualized side by side, and it should be diastolic and systolic, end diastolic and end systolic volume measurement can be measured in the same cardiac cycle. This is the advantage of doing a biplane technique, and the endocardial border can be traced carefully, so avoiding the the papillary muscle can be included in the cavity if at all it's visualized, and the LV cavity starts at the mitral angular plane, and this Simpson's technique divides the LV cavity into 20 equal height discs. The apical disc is a conical one, rest all are cylindrical discs. So the volume of each disc is calculated mathematically, and the total volume is summated. So we can measure the end diastolic volume and the end systolic volume. Sometimes tracing the endocardial border is difficult due to advancement in the 3D techniques. Nowadays, automated endocardial detection is available. So by just pointing the septal point and the lateral point and the apical point, the machine itself tracks the endocardium. So it tracks the endocardial expression from the end diastole to the end systole, and the volume can be measured in the same cardiac cycle, and the foreshortening is not a problem with the 3D measurement, as this is due to automated endocardial border detection. So the normal diastolic volume in a male is 74 is the high normal, and in a female it is 61. So if it is the volume is more than 100 ml diastolic volume and more than 45 ml of systolic volume, then it can be a severely dilated LV, or severely volume over LV can be found. So based on the end diastolic volume and end systolic volume, ejection fraction can be calculated by using the formula end diastolic volume minus end systolic volume divided by end diastolic volume. The normal ejection fraction in male is 50 to 72%. It is 2% more in females, and the reduction in ejection fraction can be further divided into 3 grades: mild, moderate, and severe. So 41 to 51 is called mild LV dysfunction. When it is between 30 to 40, then it is moderate LV dysfunction. When it is less than 30%, it is called severe LV dysfunction. For the assessment of regional wall motion of the LV cavity can be divided into various segments based on the coronary perfusion territories. There are various models available from one is 16 segment model, 17 segment model, and 18 segment model. Routinely, the 17 segment model is used for documenting coronary perfusion abnormalities, so to bring the uniformity among the echocardiography reporting. So the LV cavity can be in the 70 segment model. LV cavity can be divided into basal 1/3 segments, mid 1/3 segments, apical 1/3 segment with the LV cavity, and apical cap without the LV cavity. So the basal and mid segment are further divided into 6 segments, while the apical segment is divided into 4. So we can see the color coded for each and every blood supply. So the movement of individual segment can be visualized, and the things we should note is the one is the endocardial excursion, that is the movement of endocardium towards the center of the cavity, and the thickening of the myocardium. So when the thickening is more than 30% and the endocardium is moving 30% towards the center of the LV cavity, then it is called normal movement for that segment. If the if the thickening is lesser than that and there is no the reduced endocardial excursion, then it is called hypokinetic segment. If there is no movement at all or endocardial excursion is not there and there is no thickening, then it is called akinetic segment. If the segment is thinned out and it is moving away from the center, then it is called dyskinetic segment. So it's quite tedious to visually analyze each segment and document. So instead of that, and it also results in various inter-observer variability. So the automated techniques of 3D also provide an option to visualize individual segment of the LV. So it just follow the LV throughout the entire cardiac cycle. For example, this segment is started followed from the end diastole to the end systole to the till the next cardiac cycle starts. So this gives a idea of degree of movement and all, whether it is a normal movement or hypokinetic or dyskinetic, and the time taken for the segment to reach the maximum thickening also can be measured. It's mainly based on endocardial exertion, not on the myocardial thickening. So another method to measure the regional motion is the strain pattern. Strain pattern can be done either by a pulse wave Doppler or by using speckle tracking. Since pulse wave Doppler is angle dependent, all the segment of LV cannot be traced by this method. So, but speckle tracking can trace all the segments because it is angle independent. So, various strains useful for documenting the regional motion are longitudinal strain, transverse strain, circumferential strain, and radial strain. For the purpose of calculating left ventricular mass, we need two parameters. One is the volume of the myocardium, another is the density of the myocardium. The density of the myocardium is taken as a uniform and it is 1.05 gram per ml. So how to calculate the volume of myocardium? First, we have to measure the volume inside the epicardium, which include the volume of the myocardium, volume of the LV cavity, and also the LV cavity contents. And then we can measure the LV cavity volume alone. By subtracting these two, we will get volume of the myocardium. So this volume of epicardium and LV cavity can be measured by three methods: by either linear method using the area plane method, biplane Simpson's method, or 3D automated methods. So this is the normal value for linear method LV mass measurements. The upper value for female is 95, while for male is 115 gram per meter square. So if the mass is more than the normal reference range, then we can say that myocardium have undergone hypertrophy. The hypertrophy can be either a concentric hypertrophy or the eccentric hypertrophy. To identify what kind of hypertrophy, we need to measure something called relative wall thickness. It is just nothing but the sum of septal wall and the posterior wall or twice that of the posterior wall thickness divided by left ventricular internal diameter diastole. If the myocardial mass is more than reference range and the relative wall thickness is less than 0.42, then it is it's more than 0.42, then it is called concentric hypertrophy, which is a situation we see in most of the pressure loaded left ventricle. When the relative wall thickness is less than 0.42 and the myocardial mass is more than the reference range, then it is called eccentric hypertrophy or the volume over the left ventricle, which occurs in aortic regurgitation and mitral regurgitation. In situations where the myocardial mass is less than normal range, but the relative wall thickness is more than 0.42, then it is called concentric remodeling. So coming for quantification of the right ventricle, so mid-esophageal four-chamber view can be used by turning the probe rightward, focusing more on the right ventricle. The maximum diameter of the RV should be measured. So we can measure the basal diameter at just below the tricuspid annulus, and the maximum value is 41. In the mid RV diameter is measured at the tip of the anterior tricuspid leaflet. So the normal reference value is 35. So the outflow tract diameters RVOT measurements can be measured in RV inflow outflow view. So since in a single 2D echo, we can't see the inflow part and the outflow part simultaneously. It is not possible by 2D method to measure the volumes of a RV. So 3D methods are always used to quantify. The Tomtech software provides an option to measure the RV volume of considering both the inflow and the outflow part of the right ventricle. So the normal ejection fraction of the right ventricle is more than 45%. So coming to the methods of quantifying systolic function of the right ventricle, one method is the tricuspid annular plane systolic exertion, which measures the degree of contraction of the longitudinal fibers of free wall of the right ventricle. So for purpose of measuring this, we can use the transgastric RV inflow view, which is obtained by first taking the transgastric short axis view, turning the probe towards right, focusing on the right ventricle, and increasing the multiplane angle 90 to 110 degree. So we will get the RV inflow view, which align the lateral wall of the tricuspid annulus to the cursor. So here we can apply the M mode and we can see the degree of movement of the tricuspid annulus throughout the cardiac cycle during the systole. Our other views which can be used is the deep transgastric deep transgastric long axis view. So these views can also be used to measure pulse wave Doppler strain or spectral tracking. So if we are not able to get the transgastric views, we can use a mediastinal four-chamber view. In the diastole, the distance between the lateral annulus of the tricuspid wall and the apex of the right ventricle can be measured. During systole, the same distance is measured between the annulus and the apex of the right ventricle. And here, the difference between these two gives the. So end diastolic area can be measured by tracing the area of the right ventricle in the diastole and the systole. While tracing, care should be taken to include the trabeculations and the moderator. So the normal fractional area change can be measured by difference between the end diastolic area minus end systolic area divided by end diastolic area. The normal value is more than 33%. So next coming the quantification of left atrium. So left atrial quantification is not easy with transesophageal echocardiography because of the sector shape of the ultrasound waves. So which doesn't include whole of the left atrium, and the proximity of the ultrasound probe to near the LA causes foreshortening of the left atrium. So the calculation of LA volume is important because it gives idea about the chronicity and severity of the underlying pathology such as diastolic dysfunction or mitral stenosis, etc. So the left axis and the left atrial axis and the left ventricular axis need not be same at the same time. So when we focus on the left ventricle, we may miss the major diameter of the left atrium. So for the purpose of left atrial measurements, left atrium should be focused instead of the left ventricle. So when the left atrium elongates, the anteroposterior diameter, while the transverse axis alone increases. So measurement of left atrium in long axis view, mediastinal long axis view should be avoided. It should be measured in either fourth chamber or a two chamber. So linear measurements are not useful. So volumetric measurements are useful for quantifying left atrium. So all the guidelines are based on volume of LA. So the volume can be measured by using a Simpson's pipeline method or the area length method in the fourth chamber view and the two chamber view. While measuring the volume, left atrial appendage and pulmonary vein confluence should not be included in the volume. So since left atrium has a maximal volume at the end of the end systole, just before the mitral valve opening, all the measurements should be timed to the end systole. So here is a mediastinal view for measuring the left atrium. We can see that the sector cuts a part of the left atrium, and for the purpose of volume measurement, we will use this volume and it gives a erroneous value. And the lower part of the left atrium at the mitral annular plane, not the tip of the mitral leaflets. So in order to avoid this, we can use something called a deep transgastric four-chamber view. It can be achieved by pushing the probe further from deep transgastric five-chamber view and giving a nice anti-flexion. So this in this view, the TE probe see the left arc from the apex of the LV, and it gives views something similar to the transthoracic apical four-chamber view. so the left atrium can be measured. So, but it is not possible to get this view in many of the patients. The reference values of left atrium is upper normal is 34 ml per meter square. So it can be further divided into mild, moderate, and severely dilated based on the volume. If it is more than 48 ml per meter square, it's called severely dilated area. Similar to left atrium, right atrium can be quantified from the mediasogenital views and transgastric views. So linear methods are not useful anymore. So volumetric measurements are always better. Since the orthogonal plane of right atrium is not possible to achieve, single plane disc summation technique is advised for calculating the volume of right atrium. So the normal value for right atrial volume is 25 in male and 21 in female. For the purpose of measuring aortic annulus, we need to get the midesophageal aortic valve long axis view, and it should be measured in the mid-systole, because in mid-systole the annulus is maximum dilated, and it should be measured in the innerish to innerish connotation. So calcium should be included in the measurement. Calcium becomes part of the annulus. So another important thing while measuring the annulus, we should keep in mind is the aortic annulus is not a circular structure. There is a minor axis and a major axis. So minor axis is the one measured between the hinge point of the right coronary cusp to the intertrigon between the non-coronary cusp and the left coronary cusp. So the major axis measured from the midpoint of the right coronary cusp to the midpoint of the non-coronary cusp. So for the intraoperative purpose, we always measure the minor axis. So by the plain 2D examination, we may erroneously measure the major axis instead of the minor axis. To avoid this, it's better to take a biplane method. While short axis on the right side, I'm focusing on the this plane. In a long axis, we can measure this plane. Also, 3D is much more useful for cropping the image and giving a better value. So for aortic root measurements, we need to take the mediasophageal aortic valve long axis view, mediasophageal ascending aortic long axis view. So here, all the measurements should be made at the end diastole where the aortic valve is closed and the aorta is the. So for the uniformity on various aorta, so the measurement of diameter should be from leading edge to the leading edge technique. So not the innerish to innerish technique, similar to the aortic annulus. So all that should be taken to measure all the calipers should be at the right angle to the long axis of the aorta. So for the purpose of getting IVC, the transgastric IVC view or hepatic vein view, it can be easily achieved by tracing the IVC from the mediasophageal bicaval view, pushing the probe into the stomach, focusing on the right side on the IVC, so reducing the multiplane angle. So for the purpose of measuring diameter of the IVC, we should also be able to visualize the opening of the first hepatic vein. It should be measured 1 to 2 centimeter away from the IVC RA junction. Precisely, it should be distal to the first hepatic vein. So coming to the few basics of hemodynamic measurements, first is the measurement of flow. So since in the heart there is no continuous flow, it is a pulsatile flow. At any point when we keep a Doppler cursor, we get a flow profile similar to this. So when the velocity is traced in the y-axis and time is traced in the x-axis, we can see that velocity at the baseline as the heart starts ejecting increases, reaches the peak, and once again comes to the baseline. When all these velocities are integrated, so it gives something called velocity time integral. It is nothing but the blood at this point that travel to the distance in a single heartbeat. This is called velocity time integral, and the unit of velocity time integral is measured in centimeters. So when we multiply this length by the cross-sectional area of the LVOT, it gives a flow across the LVOT in a single heartbeat, which is nothing but the stroke volume. Then the stroke volume into the heart rate is multiplied by heart rate, gives a cardiac. So left ventricular outflow tract is always preferred site for measuring left ventricular output, because it is get dilated during systole, and it is uniformly dilated, and it's assumed to be circular in shape and easy to measure. So based on the measurement of right ventricle and left ventricle, the stroke volume can be measured independently. So this can help in measurement of degree of intracardiac stents in the patients with BSD or ASD. So in a for purpose of calculating area of activity and V20, which gives a stroke volume of the right ventricle. Similarly, stroke volume of the left ventricle can be measured. So the stroke volume of RV divided by stroke volume of LV gives it. Whenever if it is more than 1.5, then the shunt is significant and it can cause significant hemodynamic abnormalities. So this is true. This shunt calculation formula is hold good for any shunt proximal to the right ventricular outflow tract or left ventricle. What if in case where it is to this area, then this formula cannot be used. In this situation, the blood returns from pulmonary circulation to the LV can be used as a pulmonary blood flow, which can be measured from the cross-sectional area of LV or stroke volume of the LV. Similarly, the blood returning to the RV can be used as a stroke volume of the LV, so which is measured by stroke volume of the RV. So another important principles in hemodynamic measurement is the conservation of flow. So in any conduit where the blood is flowing in a uniform velocity, the flow at any point is same. So the cross-sectional area of in a situation where LVOT and aorta we consider, the flow of that LVOT and aorta is same. So in situation where the condition occurs where the cross-sectional area of point narrows, then velocity increases to keep the flow in the normal range. So here the flow is maintained at the expense of increasing velocity. So by Doppler we can measure the velocity at V1 point and V2 point. So difference in the velocity can be used to measure unknown cross-sectional area by using this formula. So in order to use this formula, there should not be any shunt in between these 2 points, and there should not be any regurgitant in this valve what we are measuring. Using this formula, we can measure the aortic valve area, mitral valve area, and also this technique can be used to measure effective regurgitation orifice area in a mitral regurgitation and aortic regurgitation using PISA technique. Another important technique used in hemodynamic measurement is the pressure measurement. So the total energy of blood flowing at any part of heart is same. So we can imagine a point where A1 and A2 where it is V1 area A1 is proximal to the narrow region and A2 is distal to the narrow region. So here the total energy can be divided into 2 parts, where the potential energy and kinetic energy. Kinetic energy is nothing but the velocity, and potential energy is nothing but the pressure. So if the blood goes to the narrow orifice, so in order to maintain the flow, as we all already saw, which is called conservation of flow, velocity increases. So as the velocity rises, to keep the total energy same, so the pressure drops. So by Doppler technique, we can measure the change in the velocity. So this change in velocity can be used to measure this change in the pressure between A1 and A2 point. So for this purpose, we use something called Bernoulli's equation. The Bernoulli's equation has 3 components. One is the convectional acceleration, another is the linear acceleration or flow acceleration, another is the viscosity friction. So the linear acceleration or floor acceleration of the peak velocity is negligible. This can be ruled out. And whenever the hematocrit is less than 60%, resistance also negligible. So the substituting values for density of the blood and correcting for the unit, we get value 4. So this is the simplified Bernoulli's equation, which helps to determine the pressure difference between the point A1 and A2. So usually the velocity V1 is less than 1, and which when it is squared, which further results in reduction in the value. So it can also be neglected. So the modified Bernoulli's equation formula is 4V2 squared. So now we know how to measure a pressure difference between 2 points. The pressure what we get is the relative pressure, not the absolute pressure. So it can be employed to measure pressure gradient between any two areas. For example, in case of aortic stenosis, the LV pressure is more than the aortic pressure. By the time when we measure the peak aortic velocity, the peak velocity in the LV is already over. So when we measure this instantaneous gradient, we won't get a peak-to-peak gradient. In order to avoid this confusion, the average of all the gradients throughout the systole can be measured, and the average gives what is called mean gradient. So nowadays, all the recommendations for valve are based on the mean gradients rather than the peak gradients. So whenever there is a shunt between two chambers, the velocity difference between these two chambers can help us to determine pressure difference between these two chambers also. So in a situation where there is a tricuspid regurgitation, the jet starts from the right ventricle, which is the originating chamber, and reaches the right atrium, which is the receiving chamber. So here it is possible to interrogate the tricuspid regurgitation jet by continuous wave Doppler in a midesophageal modified bicable view or a four-chamber view. So the peak velocity of the regurgitant jet can be measured, which gives by using the Bernoulli's equation, we can measure the pressure difference between the RV and RA during systole. So this pressure difference plus central venous pressure gives the right ventricular systolic pressure by using this formula. So right ventricular systolic pressure can be used as a surrogate for measuring pulmonary artery systolic pressure if there is no right ventricular outflow tract. Similarly, in a patient with a pulmonary regurgitation, the regurgitation starts from the pulmonary artery and reaches the right ventricle. So, by integrating the regurgitation jet and measuring the end diastolic velocity by using the Bernoulli's method, we can measure the pressure difference at the end diastole between pulmonary artery and the right ventricle. And this can be used to measure pulmonary artery diastolic pressure, as you see here. So this is the formula used for measuring pulmonary artery diastolic pressure. The right atrial pressure is used as surrogate for right ventricular end diastolic pressure. If the patient is having mitral regurgitation, we can also measure left atrial pressure by using this formula, where MR jet is integrated and peak jet velocity is included in the Bernoulli's equation. Similarly, the patient is having aortic regurgitation, we can measure the aortic left ventricular end diastolic pressure by using the aortic diastolic pressure, which is taken from the invasive arterial line when there is no alveolar obstruction or aortic stenosis. Last but not the least, echocardiography can be useful to measure pulmonary acceleration time, which is nothing but the time taken for the blood flow from baseline to reach the peak. So, if there is a severe resistance for the blood forward flow in the pulmonary vasculature, the acceleration time is reduced and resulting in narrow envelope. So this acceleration time can give a qualitative evaluation of the pulmonary artery systolic pressure. When the pulmonary acceleration time is less than 80 seconds, it indicates there is a severely elevated pulmonary artery pressure. So this is the end of my presentation. Thanks for patiently listening.
Hello. Can you hear me?
That was a very nice talk on dynamic calculations and chamber quantification. Can you hear me?
Sir, I'm not able to hear you.
Am I audible?
Madam, your voice is not audible, ma'am. Can you check
Am I
audio,
audible
please?
now? Am I
Yes,
audible
ma'am.
now?
Keep the. Yes, ma'am. Can you speak a bit loud, ma'am?
Yeah, sure, sure. Okay. Thank you, Kiruba, for that wonderful presentation. You summated everything in that beautiful presentation. It was very helpful, especially for all students and us. And any questions?
No, ma'am. As of now, there is no questions, ma'am.
Anybody has any doubts regarding the same?
Can you hear me?
Yes, sir. Can hear you.
Yes, I
This
can hear you, sir.
regarding the diameter measurements of the aortic root.
Yes, sir.
People measure leading edge to inner edge, and
Yes, sir.
Kirubanand said that it is from leading edge to leading edge. Which is the best one to do? What is the recommendation?
Uh, Sir, as per the 2015 guideline,
Yes, yes,
sir, can you hear me?
yes, yes.
Yeah, yes, sir. Sir, though that ideal thing is that measurement of inner edge to the inner edge, but as the previous recommendations all are based on leading edge to leading edge convention or leading edge to inner edge conventions for the based on the CT. So it is better to follow that convention. So the consist statement from the American Society of Echocardiography follow the same methods. So even with the CT also now they are following leading edge to leading edge to leading edge or leading edge to inner edge.
Right. Right. There's one question in chat box about what is the best view to get the pulmonary acceleration time.
View, they're asking view, right, sir?
1 minute, I'll just see.
View. Best view.
Yeah, we
Which
can use the
yeah.
Ascending aortic short axis view is a better view, or if possible, ascending aortic, or short axis view can also be used for intracranial main pulmonary artery. The deep transgastric view also can be used for RV inflow outflow view. Transgastric views can also be used. The idea is just to keep the pulse rate Doppler in the main pulmonary artery. So better with the mediastinal views rather than the transgastric views.
Morning.
Yes,
Hello.
yes, sir.
Morning.
Are you able to?
Morning.
Am I audible?
Yes, ma'am.
Yes, you're audible. You're
Yes.
audible.
Very excellent presentation, and it is certainly a difficult in the sense a very basic topic, and we do overlook it many times. Um, I just wanted to comment on one thing, which he showed. You showed pulmonary artery. Kirubanand, correct? Am I pronouncing it correct? Okay. It was a wonderful and images were very nice. When you showed pulmonary regurg, okay? Pulmonary regurg for calculating the diastolic pulmonary artery pressure. Okay.
Yes.
There you have shown the profile, velocity profile, which is, I think it's not like that. It is either a squarish parallelogram type where you can very clearly take early regurg velocity and end diastole velocity. So there are two distinct points on that, so that by taking early you can calculate mean pulmonary artery pressure, or and by taking end diastole you can take end pulmonary end diastole. Do you agree with me?
You are very
Because
correct.
it's a very beautiful diagram otherwise, but only thing is that it's very distinctly, seen. That is why. Thank you.
Kiruba, I have a doubt regarding tricuspid valve annulus measurements. So sometimes in four-chamber view,
Yes,
can you hear me? Four-chamber view, we don't get the accurate measurements. So can we go to the modified bicaval view or the RV inflow outflow view or use a biplane method? What is the recommendation?
Actually, ma'am, fourth chamber view is the recommended one. because we are measuring the maximum diameter between the septal leaflet and the anterior leaflet. If we go to the modified bicaval or bicaval view, where we are going to see only the anterior posterior leaflet, we won't get the major diameter because RB dilatation is from septal to the lateral one. So we may miss if we use that RV inflow view. And once again, biplane view is not possible in that. So if we have a 3D, it's always a better to get a 3D and measure that. But otherwise, it's always the whatever guidelines is based on the RV inflow, four chamber view.
Thank you.
About
Anybody has
LA volume also, Pooja, can I say something? About
Yes.
LA volume also, there are many, I mean, caveats, isn't it?
Yes.
LA volume.
Actually, T is not ideal one for measuring LA volume, to be frank. But in a situation where there is no data available from thoracic echo, we are supposed to measure the LA volume, and some surgeons ask for LA size for their ease of surgery, especially in a mitral surgery. So for that, we have to document some whether it is dilated or small. For that, it's better to measure the transverse diameter rather than the anteroposterior diameter to report to them.
Because
How
LA is
about
many times, sorry, LA many times dilate posteriorly, you know, it is very difficult to measure from sometimes.
Yeah.
how
And
about the deep transgastric view to get LV volumes reasonable? Deep transgastric view to get LA volumes, can we do that?
Yeah, yes, sir. Yeah, the deep transgastric 5-chamber view cannot be used because aorta comes in the view. So when we push the probe further into the stomach and when we give a nice anteflexion, we'll get something called deep transgastric 4-chamber view. That aorta is ruled out and we'll see much of the posterior LA. So here LA can be seen similar to that of the transgastric, transthoracic apical 4-chamber view. So this view is described, but many times I couldn't get that view. I tried multiple times. It's quite invasive. If we do try it multiple times, it can injure the stomach also. So care should be taken. So if at all have to do, it have to be done once or twice, and then it can be.
Kiruba, how about arch measurements in on TE? Which is the best view? Do you think that common carotid artery, where we see we can measure the aortic arch in that view? Because no guidelines mention so.
Yeah, yes, because the echo dropout region is there. So that's a definitely blind spot. So for accurate measurement, it's better to go for epicardial echo surgery. So it is accurate measurement. Also, the he mostly not
Voice.
for the not very better. So epicardial if
Voice is breaking, Kiruba.
the network issue. Can you hear me now? No?
Yeah. Now it's better.
Can you hear me?
Yes. Can hear.
Yeah. So
Okay.
because of that left bronchic crossing across, and many times we see during surgery, so we don't know which diameter we are measuring. It's either longer means aorta might expand in acute position or in a fixed position or in a out pouch. So there we may miss the maximum diameter. So these can be covered by epicardial or measurement.
That's what on TE there are no specific guidelines to measure the aortic arch. That is what we are clear about. Yeah. And how about in the deep transgastric view, the LVOT and aortic annulus measurements? How are they?
The thing is that since it is very far away from the field and the pulse repetition frequency naturally drops as the field is far away. So the 2D accuracy may not be so good in a deep transgastric view. So of course, if we have already a mechanical valve and we are supposed to measure that, we have no other way. We have to go for deep transgastric. But ideally, it is better to measure the meniscus view. This is my belief, I think. Because whenever I tried for 2D images of a tree, the quality is not so good. And we are not able to measure the. So I don't think we should comment on that.
Pooja, can I say something on this?
Sure, ma'am. Sure, sure.
See, this when it comes to measurement, it is 2D, isn't it? Huh?
Yes.
So it has to be perpendicular. So this our mid-esophageal view is best. When it comes to Doppler, it has to be parallel. So deep transgastric is for aortic, Doppler measurements like stenosis and LVOT or any other Doppler measurement over there. So that is the basic thing of echo, that 2D perpendicular and Doppler parallel. So the views are different, I think.
Do you think the measurements of the aortic diameters vary from preoperative to intraoperative measurements? Because there is
To be
patient that there's an intraoperative setting will be less as compared to preoperative.
can you hear me? Sir, I'm not aware of any contrast between these two. So I can't comment on this. So anybody else in the forum can comment.
No, it's just observation. So what happens once you get the
Rajiv?
blood? There is system
Yes, ma'am.
vasodilatation there. The diameter of the aorta may be less as compared to preoperative. Pooja, what is your idea? You were doing some study on
Sir.
Yes. So on CT scan, it is much better seen. So that's the gold standard. And on TE and transthoracic, many of the times the speckles, because of the calcium, it's very difficult to make out. So we underestimate most of the time. And also if there is a dissection flap and lot of shadowing happening because of the mitral tissue or any other tissues, that time it's quite difficult to delineate the walls of the aorta also if we are looking at aortic wall measurements. So CT is always a standard.
Yes, I agree
Sir.
with you, ma'am. Because for
Yes.
TAVI, the recommendation is not a transesophageal or a
Yes.
trans.
Yes.
It is a MDCT,
Yes.
multi-detector CT,
Yes.
combined with echo. So I totally agree.
Yes. And even for the coronary measurements,
Yes.
CT scan, which is more reliable. And obviously for any 3D, has to be good. That again comes in.
Yes.
And in Hocum surgeries, I think the 3D does a wonderful job. We are used to doing 2D, yeah, but if we have a 3D machine, the wall delineation is very good, especially with the true view mode also. We can look at the thickness
Yes.
and appreciate it on all the angles. Yeah, once they resect the tissue also. So usage of 3D in Hocum surgery might be.
So we can measure the distance from the aortic annulus where the maximum thickness is there, that we can measure, because the surgeon used to go blind in this area, so we can guide them with the distance, and also the thickness of myocardium, which can be chopped off, also can be measured.
Yes, yes.
Pooja, Pooja,
Yes, ma'am. Yes, ma'am.
we would love to see this 3D Hocum myocardial resection cases if you have sometimes. Murlidhar sir.
Yeah, so that means that Pooja has to
That-
get ready for the next
Yeah,
presentation.
because we would love to see that, because that is always a dilemma to cardiologist, how much to resect,
Yes.
or even during surgery.
It is better appreciated than the 2D, ma'am, because the LVOT is seen very beautifully. The caudal SAM is seen very nicely.
Mhm.
So the 3D is far better. We have started appreciating that nowadays. Yeah, and even the thickness very nicely we can measure because it delineates the margins very well.
Start recording, please, and collect it to show us.
Sure. I have WhatsApped Murlidhar sir's few of the recordings.
Okay.
Yeah.
So next presentation by Pooja Natarajan on hokum.
3D and Hokam.
Yeah.
I will do it eventually, sir.
Okay.
Okay, sir.
She's an aortic girl now.
Yeah, 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 yeah.
We can call her Aorta Natarajan.
Any other questions from anyone?
As of now, there is no questions, ma'am, in the chat box, ma'am.
Kripanand, very nicely done. Thank you so much for
Very
joining us.
beautiful.
I
Very
think
beautiful
we'll do
presentation.
many more talks.
Thank you. Thank
Please join us and we will go ahead.
Okay,
you.
sir.
Sure.
Forward, I have to say.
Sure.
Thank you.
Thank you, sir.
Thank you.
Enjoy
Okay.
your
Thank you.
Sunday. Thank you so
Bye,
much.
Kirubanand.
Thank you,
Thank you
Pooja.
so much.
And I
Thank you,
think
ma'am. Thank
Rajiv
you,
is
everyone.
putting that journal of advertisement of the journal. Please submit your articles. Just see that video. This
Sure.
is a brand new journal. Thank you very much. See you next Sunday. All the best.
Thank
Thank
you,
you.
sir. Bye,
Thank
Kiru.
you. Bye.
Thank you, ma'am. Thank you, sir.
Bye. Bye. Thank you, everyone.